Good day. I am Sherilyn Francis, and on behalf of the Georgia Health Information Technology Extension Center, we welcome you to today's webinar. Additionally, we invite you to connect with us at the Georgia HITEC website at www.ga-hitec.org and via social media at GA-HITEC. Georgia HITEC is Georgia's only federal and state endorsed expert to assist providers in the achievement of meaningful use of EHR technology. We are located at the Morehouse School of Medicine National Center for Primary Care. And now a few announcements. For physicians who are duly eligible for MIPS and the Medicare Incentive EHR program, the GAMIS portal is now open. Additionally, Georgia HITEC hosts virtual office hours each second and fourth Tuesday at 12:30 p.m. The week's QPP office hours will be 15 to 20 minutes of presentation followed by an open forum for question and answer. I present to you today's webinar entitled Attesting for the Medicaid Meaningful Use Incentive Program, presented by Ms. Phoebe Nelms and Ms. Selena Williams. In compliance with ACCME guidelines, the following presenters have no financial or other relationships with the manufacturers of any commercial service discussed in this educational activity. The goals for today's webinar are to review meaningful use objectives and measures, to understand documentation requirements, to highlight available resources, and to introduce Stage 3 objectives and measures. And now, Ms. Williams.
Good afternoon, everyone. Selena Williams, Program Manager for Medicaid Use Outreach. It's the first of the year, and we know that many of you have been working very hard the last few months to be ready for your 2017 Medicaid Meaningful Use Attestation. The MAPPER portal is now open, and if you have all your documentation together, you can start submitting your application. The focus of this webinar today is to specifically focus on the Medicaid Incentive Program, MIP. But there are so many acronyms, it's easy to become confused. You may also have been hearing a lot about MIPS, the Merit-Based Incentive Payment System that is part of Medicare's Quality Payment Program. The slides will explain the difference between the two, between MIP and MIPS. MIP, Medicaid Incentive Program. This is administered by Georgia Department of Community Health. And this program will continue until 2021 for all eligible professionals currently enrolled. You can access this through the GAMIS system. MIPS, M-I-P-S, Merit-Based Incentive Payment System. This is administered by CMS under the Quality Payment Program legislated by MACRA. Medicare payment reform from fee-for-service to value-based. MIP, Medicaid providers who are only eligible to participate in the Medicaid EHR Incentive Program are not subject to the Medicare payment adjustments. If providers accept Medicare Part B payments, they should participate in both programs. MIPS, Medicare eligible professionals will attest to the Advancing Care Information Performance category under MIPS, as well as improvement activities and quality measures. Level participation will result in payment adjustments. The application deadline for the Medicaid Incentive Program is April 30th, 2018. For the MIPS, it is March 31st, 2018. I will turn this over to Phoebe Nams, and she will go over a few tips for a successful attestation.
Thank you so much, Selena. That was a great overview of the difference between the two programs. One is Medicaid Incentive Program, the other has to do with those who are Medicare Part B providers. We have a polling question, and we'd just like to take a scan of the audience and to see if there are any or many of you that are eligible for both the Medicaid Incentive Program and the Merit-Based Incentive Payment System, or as part of the Quality Payment Program. So if you could just submit your answers, that would be great. We'd love to see what our audience challenges are as far as participating in. So some of you are eligible for both, and we'd like to reassure you that Georgia HITEC can assist you with either one. We are DCH funded to assist you with the Medicaid EHR Incentive Program, and we are CMS funded in partnership with Alliant Quality to help you with the MIPS program. So please feel free to reach out to GA-HITEC for assistance with either program. So we're just going to do a brief overview of the Medicaid Incentive Program. Who are the eligible professionals that can participate? Now this is if you have already enrolled in the EHR Incentive Program, and 2016 was the last year to do that. Physician types are MDs, DOs, dentists, nurse practitioners, certified nurse midwives, physician's assistants, if they lead an FQHC or an RHC. So each of these professionals would have to have a minimum of 30% Medicaid patient volume, or if you're a pediatrician, you could have 20% patient volume and still qualify for the incentive at a reduced rate. So how do you attest for the Medicaid EHR Incentive Program? You do so through the Georgia MMIS system, otherwise known as the MAPR system or MAPR portal. And we've provided the link here on the screen how you can access it. And to get into the portal to actually complete your application or your attestation for payment, you will need to have your registration ID or your RNA number. Now there is, of course, additional documentation that is required. We'll discuss those documentations next. Your meaningful use dashboard or your summary report, which also would contain not only the summary and numerators and denominators for the measures that you've been tracking through your EHR, but also would give you a readout of your core and your CQM measures. Your CQM measures that you need to report on. You'll also need to create a detailed encounter report. This will be utilized to complete your patient volume calculator. It'll help you to figure out how many patients you saw that were Medicaid fee-for-service, private pay, or one of the other payers of insurance. You'll also have to complete your patient volume calculator for program year 2017, which is available on the DCH website, and we've provided the link for you here. They also require a verification of use letter from your EHR vendor, and the completion of your security risk analysis, which you will also upload a copy of that. You don't have to create it from scratch, but it must be updated for the payment year, which will be 2017. Your screenshots for yes or no measures should also be taken during your attestation period. And if you take any exclusions, please document why you qualify for the exclusions. It can be in the form of a letter that you write, company letterhead with a signature from someone in your. So these documents need to be uploaded into your application to verify your meeting the requirements and therefore being able to receive your incentive payment. And because any program that we participate in that is funded by government funds also can lead to an audit, so we want to keep all the documentation either digitally or back up with a printout of your attestation for at least 6 years from the date of your attestation. So we want to share a few reminders and tips with you. The reporting period for 2017 is a consecutive 90-day period. You must have a certified electronic health record, 2014 certified, and you would verify that with your verification of use letter from your vendor. So the reporting period for your patient volume calculator and your detailed encounter report should be for the same consecutive 90-day period. Your meaningful use dashboard may be from a different 90-day period, but the detailed encounter report and the patient volume calculator, same 90-day period. So what needs to be included in that detailed encounter report? It should only capture one encounter per patient per day. If you notice duplicates, please remove duplicates. so that your report will be accurate and meet the requirements of the program. It should also include the provider's name, the patient's name or a patient ID, the date the service was rendered, and who paid for the service, the payer type. We really like to see this in an Excel format, but some people generate a PDF. It makes it easier, or it may be the only way they can export it from their system. But if it is in a PDF, then please provide a summary list of all the payer types in an Excel document so that the reviewers will be able to easily assess what you have. A few more reminders and tips. Many people have found it very helpful to create a meaningful use folder for each of the payment years that they collect their documents for, and save all those documents that you want to upload so they're all in the same place. So that when you go to attest, you're not trying to find everything that you need. And also it helps you to save these documents for the period of time required to be covered in case of an audit. There is a limit to the file size that you can upload into the macro system. It must not be larger than 4 megabytes. If you have a file, for example, that is larger, you would have to divide it into several smaller files. And again, we want to reiterate that if you create your detailed encounter report and save it as a PDF, please create a summary by payer type. And the screenshots that you use to support your attestation for certain of the measures should have a date stamp from your system to show that they were in force and being used during the reporting period. We really want to encourage you to plan for your next attestation now. Check your meaningful use dashboard often, at least monthly, to be sure that everything is on track. It makes it so much easier as you go towards your application. So we have another polling question that we'd like to present to you guys, just to keep you engaged. What is the maximum size of a file that can be uploaded as supporting documentation in your attestation? Thank you so much. That is just about 100%. As we move forward, you want to be sure that you have everything you need to complete your attestation. So this resource will help you to find the letter that the product number for your certified electronic health record. So you would go to the website and put in the EHR vendor, and then find the version that you are currently using. So we need this information, but it is not sufficient to just use the information you get from the site. You also need your verification of use letter. We also want to remind you that the format for your documents can include macros. So you must save the patient volume calculator into the right format so that it will be accessible to the reviewer. So what are these objectives and measures? We're just going to go over them quickly so that you make sure you've checked everything off as you go to submit. We have 10 measures, 10 objectives, along with the measures that comprise the 2017 Modified Stage 2 requirements. Number 1, as you can read here, the link below will help you to find this on the CMS website in more detail, and you can read each specification sheet in detail to make sure that you covered all the requirements. So we would like to share that link with you, and we're just going to go on and talk about each objective. Number 1 is the security risk analysis. This is so very important. We have gotten feedback that the reason some people, most, who fail an audit do so is because they have not completed the security risk analysis. Not only is this a requirement for participation in the GA-HITEC Incentive Program, but it actually is a requirement, HIPAA security rule. And so at least once each calendar year, providers or practice managers must conduct or review a security risk analysis of their certified electronic health record technology. And the reason you really want to do this, you know the climate we live in. Cyber threats are abundant, becoming more and more so. So you want to be able to identify any security deficiencies that might need to be corrected. Not only do we want to protect our patients' health information, we also want to protect your practices. Why do I say protect your practice? Because HIPAA is conducting more and more audits, and the fines are substantial, and we do not want to put ourselves at risk for any of that. So, of course, it would be wise to do this if you go through installing any new equipment or software that stores, transmits, or accesses electronic protected health information. And as mentioned, failure to conduct a security risk analysis is the number one reason for failing an audit. And there are tip sheets that are very helpful that are provided on the CMS website and also through the Office of the National Coordinator to help you review the requirements of a security risk analysis. And in order to give you, also you can find resources from the Department of Health and Human Services. GA-HITEC has a template that we would be happy to share with you that has been very useful for small practices, and it helps you to meet all the requirements of the security risk analysis and is recognized by DCH as a valid SRA. So we'd be happy to share that with you if you contact us for assistance. And remember, keep all your documentation for at least 6 years from the date of attestation, including your security risk. So we'll move on to objective number 2, the use of clinical decision support to improve the performance on high priority health conditions. Clinical decision support is such a valuable tool because it really can help providers to cope with the overwhelming amount of information that's available to support patient care. It could take the form of a reminder or an order set, condition-specific order sets, clinical guidelines, or focused data reports and summaries unique to the patient you're seeing. And so we want you to note that there are 2 measures associated with this objective, and that your EHR formulary functionality must be enabled, and be sure that it is set so that you capture your drug, and drug allergy interaction checks, and that it's reporting on that for an accurate MU summary on your dashboard. Doing the work, we want to be sure that you're capturing and able to use the report to verify your activity. So objective number 3 is computerized provider order entry. So you would use your EHR to capture information on at least 60%, well, let's not say at least, more than. It's important that we realize that it's not the 60%, but more than 60% of medication orders created by the EP is recorded using your EHR technology. 30% for laboratory orders, more than 30% for radiology orders. And you'll note the exclusions here for providers who write fewer than 100 medication orders or fewer than 100 lab orders or fewer than 100 radiology orders during the report. So moving on to objective number 4, electronic prescribing. So this requires that you generate and transmit permissible prescriptions electronically for more than 50% of the permissible prescriptions, and that they be queried for a drug formulary and transmitted electronically through your EHR technology. The exclusion would be if a provider writes 100, less than 100 permissible prescriptions, or if they don't have a pharmacy within 10 miles that accepts electronic prescriptions. So most people are pretty set up to do this, and it's established in their practice workflow. So for objective 5, this is the one that has some challenges, And we want to point you to the tip sheets that are available on CMS. They can be very helpful. And we encourage you to take advantage of that, as well as reach out to GA-HITEC for additional resources that we can steer you towards to help facilitate health information. So this requires that a clinician who transitions their patient to another setting of care or to another provider, that they send along with them the summary of care record for each transition of care or referral. So you're required to use your electronic health record technology to create the summary of care and to electronically transmit that to a receiving provider for more than 10% of the people you refer. So we're making great progress in this area, but it's still somewhat challenging, especially for small practices. And then I said, please reach out to GA-HITEC. We'll try to share resources with you to help you overcome the challenges of this. And measure number 6. We want to use our electronic health record technology to share information with the patient that we're seeing that's relevant to them and their condition. So it's not that the EHR has to generate the educational materials, it just has to identify what would be a good resource to share with the patient. And you have to do this for more than 10% of all the patients that come to your office for a visit during the reporting period. So many clinicians already do that. And we're really, really thankful for the hard work that you do in this area. I just want to backtrack a little bit to objective number 5. And be sure that we include the exclusions for that one, because for many small practices, they may not do that many referrals. So if a clinician transfers a patient to another setting or refers a patient to another provider less than 100 times during the 90-day reporting period for 2017, then they can claim the exclusion for this measure. So objective number 7, medication reconciliation. We know that this is a very important safety measure. So any physician or eligible professional who receives a patient from another setting of care or another provider, and they believe that an encounter is relevant, would perform medication reconciliation. So many practices just, as a matter of course, they just always perform the med rec. It improves patient safety. And so the measure would be that you do this for more than 50% of the transitions of care. Patient comes into your practice. And the exclusion for this would be that if you don't have any transitions of care during the reporting period. So, as mentioned before, it really is a very important element of patient safety, especially for patients who use multiple pharmacies, have comorbidity factors, or they may have several people assisting with their care, or they may have many healthcare providers, many specialists. So it's very important to create an accurate medication list when they come into your practice, because this can reduce medication errors or over-medication by capturing a complete and accurate list of all the medications that they're taking, even those non-prescription and alternative medications. And by comparing this list with both documentations in the patient's medical record during their visit to your office, as well as if they're admitted to or discharged from the hospital or another inpatient setting, it really helps to protect our valuable patients. Objective number 8, patient electronic access. This is really geared towards engaging our patients in their own care. And so this is really not going away. And although it is challenging at times to get patients engaged, depending on the who makes up your patient population, I really want to try and find creative ways to get this done. And to help us with that, there's a tip sheet linked to it at the bottom of this slide that CMS has provided resources to help give us ingenious ideas or suggestions how we can incorporate more patient engagement in our work. So it means that we are to provide patients the ability to view online, download, and transmit their health information within 4 business days of the information being available to the provider. So there are 2 measures in this objective. Measure 1, you'll have to have more than 50% of all unique patients that you see during the EHR reporting period be able to view, download, and transmit their health information. Of course, that's subject to the clinician's discretion in some cases. And measure 2, more than 5% of unique patients seen during the reporting period view, download, or transmit to a third party their health information. And there are some exclusions to this measure if you don't create any of the information listed, or if you neither order nor create any of the information listed for inclusion as part of the measures except for the patient name, and office contact information. Or if you conduct 50% or more of your patient encounters in a county that does not have 50% or more of its housing units with 4 megabytes of broadband availability according to the latest information available from the FCC. So there may be very, very few instances in the state of Georgia where in remote areas, rural areas, where they may be able to meet that exclusion. And also, there are tip sheets available on the CMS website which allow for some circumstances where patients can opt out and you can still count them in your numerator, but you would have to create an opt-out form and record their selection of that option and keep that on file and as a part of your audit preparedness should there ever be a question about the exclusion that you claim for this measure or for the numbers that you report for this measure. Objective number 9, secure electronic messaging. Using secure electronic messaging to communicate with patients on relevant, I am getting tongue-tied, relevant health information. So we want to report on more than 5% of our unique patients that we sent them a secure message or that we responded to a secure message sent by the patient during the EHR reporting period. Of course, there's an exclusion for this one. If you have limited broadband availability in your area and if you have no office visits during the EHR reporting period. So again, this is to promote patient engagement and accessibility to information by the clinic. Objective 10, public health reporting. There are 3 measures under this objective. So it is to encourage active engagement with the public health agency to submit electronic public health data from your EHR, unless, of course, it's prohibited or against applicable law. So, of course, here in Georgia, we have the immunization registry, GRITS, which many people are, especially pediatricians, report to GRITS. And so if you are actively engaged in sending information to GRITS, then you would meet this measure. Syndromic surveillance is available for hospitals, but not for small ambulatory practices in Georgia. And so you'll notice the link at the bottom of the slide. The Department of Public Health, you can complete the form that they have related to meaningful use, because syndromic surveillance is not available for us. Some practices are signed up with specialized registries, and they submit data to these registries. And so that's how you can meet measure number 3. You can also request of an organization that you belong to see if they do have a registry and obtain their response and keep that on file as documentation for your, if you choose to, are able to claim an exclusion for this measure or documentation of your access to the registry. So those are the 10 objectives for modified stage 2 meaningful use. Ran over them pretty quickly because you guys who are working on this are just really doing a check to make sure that you have all your information together to meet the requirements. And for those who are looking forward to stage 3, we have a very brief synopsis of the stage 3 objectives here. Some things have remained the same, and other things require a little more effort and focus. And of course, the primary thing we must remember about stage 3, is that your EHR has to be certified 2015. So in 2018, all providers will be required to participate in stage 3, regardless of their prior participation. If you're able, if you have a 2015 certified EHR technology, then you could attest to stage 3 in 2017. And to meet the requirements for 2015, it would be, for stage 3, it would be good to become familiar with these objectives right now, because as it stands, a full year's reporting is required. There are no alternate exclusions or specifications available in stage 3. We provided the link from CMS to review the requirements for stage 3. Just as we reviewed the ones for stage 2, it's broken down with lots of information that can help you be ready. And we would like to be of assistance if you would like to move forward with stage 3. Reach out to us. We'll just go over them very, very, very briefly. I'm going to go back one slide. So, of course, the security risk analysis, that remains the same. It has to be updated so that we can protect patient information. E-prescribing, the percentage is more than 60% of all permissible prescriptions written by the EP are queried for a drug formulary and transmitted electronically. So you have to have the 60% transmitted electronically and check for that drug formulary. For objective 3, clinical decision support, it requires 5 clinical decision support rules that are related to 4 clinical quality measures for high priority health conditions related to your scope of practice. And it also includes doing that drug and drug allergy interaction check for the entire reporting period. For number 4, computerized provider order entry, that would be more than 60% of medication orders, which remains the same, but then laboratory orders would be more than 60%, and more than 60% of diagnostic imaging orders as well. And objective 5, patient electronic access, more than 80% of all unique patients would be given the opportunity to view, download, and transmit their health information. And this is something new, that they would also use a selected application of their choice that can interrelate with your EHR to access their electronic personal health information. As well as 35% of the patients that are provided electronic access to educational materials that apply to their specific case. And number 6, the coordination of care. This is very detailed and in-depth, and I really encourage you to read this measure specification very closely. So really the emphasis is to use our electronic health record technology to promote patient engagement with the patient themselves and their authorized caregivers around their care. And so this may require some creative thinking and workflow adjustments, but it's doable. And health information exchange to provide those summary of care records whenever you do a transition or whenever you receive a new patient into your practice, using our electronic health record technology. Public health reporting, again, being in active engagement with the public health agency or a clinical data registry to submit health data that really can have a meaningful impact on evidence-based research and the science behind why we do what we do. So now we've come to the end of what we've prepared for you, and I'd like to open up the discussion to your questions. We will try to answer them as best we can and reach out to you to provide one-on-one help if you will use the contact information that is provided on this slide.
When is the last day to report for the 2017 date?
Okay, so we want to be sure that we are talking about the correct program. So for the Medicaid EHR Incentive Program, the attestation or application deadline is April 30th. However, for those who might be thinking about the Medicare MIPS program, excuse me, that application deadline is March, or the submission deadline. It's not really the same as the MAPR portal. It's a different configuration. You can continuously submit or modify your data. But for the Medicaid EHR Incentive Program, April 30th, 2018 is the deadline. And for Medicare, QPP, MIPS, it's March 31st, 2018.
Thank you. Just as a note, the webinar presentation is currently available for download. It can be found in the lower left pod. Additionally, the resources which were discussed during today's webinar can be found in the lower middle pod. And we are now open for Q&A, so if you have any questions, please feel free to submit them in the chat pod, but we will also be reviewing the registration questions. So we have a question regarding the public health reporting measures. Would it be better to work with a vendor to collect these public health reporting measures, or can a provider who has no experience or expertise in secondary data analysis use, what can a provider do?
Okay, that's a very good question. There are CMS-approved registries that you can find. We'd be happy if you reach out to us. We'd be happy to share a link to that resource with you. So some providers who are already members of professional associations can use those organizations to aggregate and submit their data. And so that is a good suggestion. You just have to report on what their requirements are for the registry.
Okay, our next question. Can you please give us more detail on the 4% negative adjustment?
Okay, so as described in the outset, the very beginning of our presentation, where this webinar is primarily focused on the Medicaid EHR Incentive Program, which does not have any negative consequences for non-participation. It's totally voluntary whether a clinician attests for the Meaningful Use Medicaid Incentive Program to receive a payment of $8,000 $500 for their meeting the requirements of the meaningful use objectives that we discussed. We also talked about the Quality Payment Program MIPS track, which is for Medicare Part B billers, clinicians who take care of patients who are Medicare Part B eligible. The 4% penalty comes into play with that program, Quality Payment Program MIPS track. Any clinician who sees over 100 Medicare Part B patients and bills Medicare over $30,000 is required to submit data on the Quality Payment Program portal or through a registry, or submit data through their claims in order to avoid a 4% negative payment adjustment on their 2019 reimbursements based on what they have done or reported in 2017. So we're talking about two different programs. For the Medicare part, there's a 4% penalty if you submit no data whatsoever. For Medicaid, there is no penalty. There's no negative consequence for not completing an attestation at this time.
LaWanda would like to know, do we only have to attest for 5 CQMs or a total of 9?
Selena?
Yes. According to the recent update, you can attest to only 6 CQMs. It is no longer 9, so you can use 6, and that would be suffice.
During your presentation, you mentioned that GA-HITEC has a risk analysis template. Where can the participants of today's webinar access that template?
Yes, you'll notice on the slide that's up on the screen the email address for Selena Williams. She is the program manager for the Meaningful Use Medicaid Incentive Program. And feel free to send a request to Selena Williams, and she'd be happy to share that template with you.
Brian wants to know, what is the incentive amount payable for attesting?
So under the Medicaid EHR Incentive Program, each eligible clinician that meets the requirements for meaningful use and completes a successful attestation, the payment for each year is $8,500. So that's per clinician. If you have more, let's say you have 5 clinicians in your practice, that's 5 times $8,500 for each one that successfully completes an attestation meeting all the meaningful use requirements. The first payment was $21,250, and of course no one could get into the program after 2016. So if you have received at least one payment under the Medicaid EHR Incentive Program, then you can successfully apply and attest to receive subsequent payments up until 2021. You do not have to submit applications consecutively. You can skip years. So if you are in the program and you meet the requirements, then you can receive that $8,500 incentive payment.
Can a provider submit for meaningful use for last year even if they did not participate?
I would like you to contact me directly so that I can do some research on that question. My initial answer would be no. Once the deadlines have passed, then there's no additional opportunity to submit an application for incentive. So the deadlines are pretty set in stone. And if you missed out on the opportunity, then I'm sorry. You can just move forward with subsequent payments.
What should an EP begin to collect as of today in order to prepare for an audit?
That is a great question. So you can use the objectives as your guide. So you would want to have your security risk analysis, a copy of that. Any screenshots that you take of your clinical decision support rules in effect, you want to keep that. Your verification of use letter, your meaningful use report, which summarizes all of those activities that you reported on. That would be a very good documentation to maintain. Anything that you take as an exclusion, the proof that you have of qualifying for that exclusion. So those are the things that come to mind, and that's a great topic to maybe include in a future webinar. I know occasionally Department of Community Health, with their partner Myers and Stauffer, creates audit preparedness webinars that are very helpful, and they review the information that you should have on hand to be able to present should you be selected randomly for an audit.
Is there a cutoff time for new providers to participate in the program?
So as we mentioned at the outset, we'll start with the Medicare MIPS program. That is a new program. The legislation was written in 2015, and 2017 is the first year that it has been implemented. So for Medicare Part B, clinicians who meet the threshold of 100 Medicare Part B patients billing Medicare over $30,000, that's a new program, and the deadline for submitting 2017 data is March 31st, 2018. Now, for the Medicare EHR Incentive Program, any clinician who did not submit an application for the Medicaid, see, I'm getting them mixed up, the Medicaid EHR Incentive Program, any physician or clinician who has not already enrolled in the program and has not received the first payment labeled AIU, Adopt, Implement, Upgrade, the first payment of $21,250, they cannot enter the Medicaid EHR Incentive Program.
Okay, so for any clinician who did not enter the Medicaid EHR Incentive Program by December 31st of 2016, and you have not received your initial payment of $21,250, then the window for entering the Medicaid EHR Incentive Program has closed, and that is unfortunately a missed opportunity. But if you are in the program already, even if you entered in a different state, then please contact us so we can check your status to see your eligibility, what payments you've received, if you provide us with your NPI number. So we can check for you. But unless you have already entered the program, that opportunity has passed, unfortunately.
And we've now reached the conclusion of our webinar. To provide two announcements, again, for physicians who are duly eligible for MIPS and the Medicaid EHR Incentive Program, the GAMIS portal is now open. Additionally, we invite you to join us each second and fourth Tuesday for the virtual office hours. The virtual office hours format is 15 to 20 minutes of presentation followed by an open forum for question and answer. So you can receive answers to all of your burning QPP questions. Our experts, Liz and Phoebe, will be there to guide you through your quality payment program concerns, questions, and opportunities. On behalf of Georgia HITEC, we thank you for attending today's webinar, and we hope that you have a wonderful afternoon.